we released the South Australian Rural Generalist Pathway Phase 2 evaluation report in November of last year. Since then, the Australian Journal of Rural Health article from Barker and colleagues has been published, and you may have just seen Ilse present these findings in her previous session. We also have evaluation reports from Queensland from 2014 and 2016, which evaluated the generalist pathway in the early days, and I'll report on the similarities with our findings on these. Our research is using a 3-phase process. At each stage, we're involving the trainees themselves, their supervisors, line managers, clinical leads, and the central project team. The results of our research have some similarities and differences to the research that has previously been undertaken. Firstly, due to funding, SA Health has recruited AHPs from existing staff across regional local health networks in South Australia. Some trainees nominated themselves for the pathway in an expression of interest, and others were nominated by a supervisor, manager, or clinical lead. Comparatively, the first cohorts in Queensland recruited supernumerary training positions, so the trainees started with the intention of undertaking the pathway. At the midpoint of the generalist pathway, we have all 5 level 2 trainees continuing and 4 level 1s, with 6 level 1s discontinuing. The level 1s have left for a range of reasons, including a desire to be closer to family or partners, job opportunities, challenges with clinical or organisational support, and workload pressures. Interestingly, the first trainee cohorts in Queensland did not have any attrition. It's important to note, however, that there were a range of differences with the way the states implemented the pathway, which would have had an impact, including, as I said, that existing staff were recruited in South Australia, so they were not an additional resource, and they didn't all nominate themselves. Jodie May from SA Health and I have a lightning presentation at the conference discussing how the findings of our research have been used to change the way trainees were selected for the second cohort, which have started this year. Despite the attrition with the level 1 trainees, when we compared the retention rate of AHP1s or base grade positions in regional local health networks in South Australia at the same time, the level 1 trainees had stayed longer, which was a positive find. We will continue to track this in phase 3. The continuing trainees mostly reported a desire to continue working in rural and remote areas for at least 3 years. When we asked trainees, their line managers and supervisors about the actual training course, their results were similar to Barker's research. Many of the trainees found the training was helping them increase their knowledge and skills across a range of clinical areas, and they were learning about how to undertake service development and quality improvement activities. They were enjoying the opportunity to be involved in these activities early in their career. However, they consistently reported that they had limited time to implement the projects in their current workload. Some trainees found their proposals for projects did not move beyond the initial stages. Some did find time to implement the projects, while others were planning to implement them after they had finished the training. This finding is in line with the evaluation undertaken by Southern Cross in 2015, which made a range of recommendations about projects, including making them very small, simple, realistic, and achievable in the time frame. Some trainees had difficulty aligning the training content with their clinical roles or have found limited relevant options for their profession. Interestingly, Barker's study included mostly physio trainees and mostly level 1s and mostly Queenslanders. We found that the physios and OTs have generally been able to translate their learning into practice, whereas our podiatry and speech pathology trainees have not always found the content to be relevant to their caseload. Barker's positive findings around the relevance of topics, consolidation of skills, and flexibility of online learning are generally similar to the SA context. Similarly, the challenge of time and fitting it all in, needing more options for learning activities, and insufficient feedback and earlier access to modules were all consistent with our findings as well. Consistently, participants in phase 2 recognised the support available from clinical supervisors, senior clinicians, line managers, clinical leads, and the project management team as significant enablers for the success of the pathway. These stakeholders were generally positive about the pathway, were already seeing a range of positive impacts for trainees, their teams and consumers. They were happy to recommend the pathway to others and be involved again, and they reported similar challenges to the trainees around time, relevance of topics and implementation of projects. Again, this is consistent with Barker and colleagues who found overall the pathway was well received, an effective training program and a mechanism for building rural and remote health workforces. Although the South Australian group were in established roles, they may have not had as much time to implement the projects as those in supernumerary positions in other states. A range of factors for trainee success was explored, including temperament and characteristics, years of experience, location, profession, and rural background. And we will continue to explore these for trends in phase 3. We're also undertaking a cost effectiveness study, which will conclude in phase 3. So if anyone has any other questions, they're welcome to pop them in the chat box, or you can email me, and my email address is there on the screen.